also happy to be able to discuss one of our more recent interests, primary central nervous system vasculitis. This is an uncommon or rare condition, and if you're a family practitioner out in a rural area, you're unlikely to see a case in the next year or two. But if you're in a referral center, the chances are greater that you're going to see something about that, or it's going to come up, especially if you see patients who have progressive neurologic disorders, either diffuse or focal, and there's no readily apparent cause. So then the question comes up, and for that reason you need to know something about it. Primary CNS vasculitis can simply be defined as an inflammatory process with vascular lesions limited to the brain and spinal cord. You have to have a way to define these and separate them out, just like last night we talked about giant cell arteritis, which has been one of my interests for many years. Secondary vasculitis is mainly something you need to keep track of if you're going to make a diagnosis of primary CNS vasculitis. It's related to some other disease that's known or recognizable. It has vascular lesions elsewhere in the body, such as systemic vasculitis, connective tissue disorders, drugs, and infectious diseases. Regarding this condition, it was described relatively recently. Harbitz, a pathologist, in 1922, in an article in the American Journal of Medical Science, which was a prominent journal in those days. It still exists, but it's pretty small and obscure nowadays. But at any rate, he described several case histories. And in retrospect, one of those fit with the diagnosis of primary CNS vasculitis. These were unknown forms of vasculitis, or previously poorly defined or undescribed, and he was just sort of putting them out there for people to recognize. And indeed they did. In the next years after 1922, there really weren't any reports out, but between 1950 and 1980, there were approximately 25 cases, most again diagnosed at autopsy because people didn't recognize the clinical presentations and they got worse and eventually died. And then surprisingly at post-mortem, the patients had this vasculitis limited to the CNS. And even in some of these cases, at those times, patients had vascular lesions in other organs, so they really weren't strictly CNS vasculitis. And the diagnostic criteria weren't the same in all of the cases. And because the authors of these individual cases really weren't so aware of what other authors were doing, the condition was described under a variety of terms: non-infectious granulomatous angiitis. The differential of tuberculosis or syphilis always tended to come up. Giant cell arteritis of the CNS, because there was often a granulomatous inflammatory reaction around the blood vessels. Isolated, indicating that it wasn't elsewhere in the body. Primary angiitis of the CNS. Primary CNS vasculitis, which is a term we use, sometimes criticized by others for not using the different term. Benign angiopathy of the CNS, no longer used, and the authors of this have kind of concluded that what they were describing was a vasospasm rather than an inflammatory process. The diagnostic criteria are simple and empiric, and were suggested by Calabrese and Malik in an article in 1988 where they described several cases. And so the criteria indicate that a patient should have a recent history or findings of an acquired, unexplained neurologic deficit, that there should be the presence of either classic angiographic or histologic features within the CNS indicating the type of pathology, and there should be no evidence of some other disease that could explain these findings. And you know, they've never been tested, but they work out pretty well, and so there's no problem. Over about a 15 or 16-year period between 1991 and 2007, before our reports, there were 8 reports which included 10 or more cases. And I just summarized those to sort of give each article a little bit more weight. And if we total those up, there were 121 cases in the literature. Some of the case reports were kind of hard, it was kind of hard to tell whether they really had this condition. So 40 of those were diagnosed by biopsy or autopsy, and 81 by angiograms. And it's interesting to note that all but 3 of these 40 were in 2 reports by J.T. Lee, who used to be at our place before he left to California and then had lung cancer and died, and Al Rawi, another pathologist, who reported over 30 of them. So as angiograms became more common after 1988 and the technology improved, so the utilization was more widespread, it was much easier to diagnose this by angiograms than it would be by brain pathology. Brain pathology, brain biopsy sounds very invasive, very dangerous and risky, which in a sense it could be. It isn't often though. And so it would be much easier to get an angiogram. And angiographic changes compatible with vasculitis got to be pretty well defined. Smooth-walled, narrowed, tapered areas separated by smooth-walled, dilated areas, different from arteriosclerosis or thrombosis. And so that was the way the diagnosis was made. However, as experience increased, it was found that these findings, which were compatible with vasculitis, compatible because you don't have a tissue diagnosis in those cases, were not specific for vasculitis of the CNS necessarily. They're where you had to be aware that the systemic vasculitis could cause them, but then other kinds of conditions, such as infections of a variety of kinds, drug uses, cocaine, vasospastic substances, neoplasms, a very rare angioproliferative disorder involving the blood vessels, just a few cases reported, and then other conditions, fibromuscular dysplasia, thrombotic thrombocytopenic purpura, sickle cell disease, neurofibromatosis, arteriosclerosis, and then a variety of things, including amyloid cerebral angiopathy, which is a pathologic diagnosis. So you probably couldn't make that before biopsy. Turns out many of these diseases can be separated, but because of associated symptoms, systemic vasculitis, be chest disease. So you kind of get to those diagnoses. There would be a history of these drug uses, and so that would be the way you would make that. And then obviously if you're having a systemic infection, you could find that out. And then the one that seems to be most troublesome is the reversible cerebral vasoconstriction syndrome. The patients develop findings, and the differential diagnosis between that and primary CNS vasculitis is often quite difficult and quite controversial. So I have a slide here that I've taken after Gerstensen and colleagues in an article in the Canadian Journal of Neurology, differentiating the two. And you can differentiate the two preponderantly. You know, you have groups that seem to separate out pretty well. In the vasoconstriction syndrome, you have typically, at the onset, a thunderclap headache. These are severe headaches that reach a maximum intensity and are kind of disabling within just 1 to 3, 4, 5 minutes. And so it's a rather dramatic onset. Could be seen as with a subarachnoid hemorrhage also. So it's not only in the vasoconstriction syndrome, but vasoconstriction can occur with subarachnoid hemorrhages. So in central nervous system vasculitis, the onset is much slower, progressive headaches. Headaches are common, of course. There's a difference in the course of the headache, and rarely, if ever, does one have a thunderclap headache in vasculitis. There's a female preponderance, but in individual cases, that really is not going to be helpful. In the vasoconstriction, there's a history of pregnancy, vasoconstricting substances, as I mentioned, or exertion, or some other triggering event that can be obtained in the history, whereas none of these seem to pertain or are seen in the vasculitis. So the majority of patients do have one of these triggering episodes, and that's very helpful in the diagnosis. MRIs tend to show minimal abnormalities, whereas they're almost always abnormal in vasculitis. Again, in a few cases or a minority of the vasoconstriction syndrome, there could be a hemorrhage, there could be a very severe vasoconstriction. You'd have ischemia and infarctions and maybe even a vascular hemorrhage. So that would be difficult. Then the CSF tends to show minimal abnormalities or normal, whereas it's abnormal in over 90% of the cases of vasculitis. The vasoconstriction tends to be excuse me, at the base of the brain, but various vessels may be involved. And this is sort of where the controversy has come also, in that some cases in the literature might have 2 or 3 narrowed spots in one blood vessel, and then they're diagnosed as vasculitis. And that becomes kind of iffy. You need to be overwhelmingly sure of what's going on as much as you can to diagnose vasculitis, because the therapy can be hazardous to your health. Vasoconstriction resolves in 1 to 3 months, whereas it's progressive. So follow-up angiogram would tend to be normal after 3 months, where it would be unchanged, or even worse if your therapy has been inadequate in vasculitis. The therapy, as I mentioned, is quite different. You need calcium channel blockers or something to relieve the vasospasm, whereas glucocorticoids and cyclophosphamide are indicated here. What I'd like to do the rest of the time is go over the results of our studies with this in recent years. We had a patient that had overlapping symptoms between giant cell arteritis and CNS vasculitis, and we started to look at it, and we could see that there seemed to be a lot of confusion and a paucity of reports on primary CNS vasculitis, so we kind of developed an interest and pursued that. So over 25 years, 83 through 2007, we looked at all potential cases. Now, at the Mayo Clinic, there is a good record system. So the diagnoses are all categorized, and we can search the records for anything that sounds like it could possibly be CNS vasculitis, and then go through the records and eliminate most of them. But it's a lot of work, but we can be increasingly certain that we have the right diagnosis if we do that. And we can talk about the verifiability of that too. And that cases then, because of the controversy between angiographically diagnosed ones and tissue diagnosed ones, we compared those to see if there was a difference, see if we had some clinical changes. The patients then were followed, sort of prospective, retrospective, to death to the last day of the visit or through some correspondence. And then Teresa Christensen, our statistician, performed a number of statistical analyses to see if the differences we were coming up with were meaningful. This slide shows the way the 131 patients were diagnosed. In 24 or 18%, there was a positive biopsy, but an angiogram wasn't done. They went right for a biopsy. There might have been a question of a possible tumor or some other process, so an angiogram was never accomplished. In addition, there were 10 who had an angiogram, but it was negative, but the biopsy was positive. And we'll go into those a little bit more later. Then there were 7 who had a positive biopsy and also angiograms. And then there were 68 who had positive angiograms and a biopsy was not obtained. And then an angiogram positive and a tissue biopsy was done, but it was negative. So 2/3 of them were diagnosed by angiograms and about 1/3 by a positive tissue diagnosis. And those are the groups we compared. And to be certain, as much as we could, that the angiograms really represented vasculitis, we decided to have a criterion, the basic Calabrese-Malik criteria, plus that the vessels involved, there were multiple vessels involved, so 100% of those of our patients. Angiograms were performed in 107, and they showed vasculitic changes or compatible with vasculitis in 97. And that most of them had bilateral changes. Large vessels were involved in 2/3. Sometimes these were unilateral, but mostly bilateral. And small vessels were involved in most of them. So a lot of the patients had small and large vessels involved, but some of them just had one or the other. And that kind of plays out a little bit later in the clinical symptoms and findings and our quest to separate, to act like splitters rather than lumpers in this disease. This is a typical, very nice angiogram showing a longer segment, smooth-walled narrowed segment, then it goes back to normal caliber, and a dilated area separated by two narrowed areas. Another area with a little more irregularity, but at least no sharp edges suggesting thrombosis or arteriosclerosis. This is what you'd like to see in multiple vessels and bilateral. And an MR angiogram, again showing changes with stenoses in two arteries in this view, a narrowed area right here, and then an irregular caliber over here, compatible with vasculitis. MR angiograms are less invasive, but they're a little less sensitive. So this might be the way to start, but if you're up against it, you may end up doing a regular angiogram anyway. And this tells about the pathology. There were biopsies in 63 cases, negative in 22, positive in 39, and then in 2 patients the diagnosis was made at autopsy. They came in, had a very rapidly progressive course, and then they just died, and at autopsy the diagnosis was made. The type of histopathology was interesting to us. As you noted, one of the older terms was granulomatous or giant cell arteritis of the CNS. And the granulomatous histopathology was present in the majority of the cases, by a little bit. 8 of them had only a lymphocytic pattern. 9 of them had a necrotizing pattern with polymorphonuclear leukocyte invasion and destruction predominantly, and 1 had both of these findings. So this kind of alerted us. Dylan Miller and Caterina Giannini are the pathologists, and it was kind of routine for them, but we started, Carlos Alvarani, my collaborator, and I started thinking that maybe this was an indication that all was not just one simple homogeneous disease. And so we were alerted to that. The other alternative was that perhaps a lymphocytic histopathology was just sort of a transitory phase that would again develop into either granulomatous or necrotizing. And we had no evidence initially. But then we had found that 4 patients had a second biopsy separated by months from the first biopsy. In all of those cases, the histopathology was the same as the first specimen. So at least there's some evidence that this was not a progressive and changing histopathology, and that it was pretty consistent throughout the course of the illness. And that's our contention now. And that, interestingly, amyloid deposits were found in 11 of the patients in this category. Now, amyloid is a very common deposit, a substance deposited in older individuals and in Alzheimer's disease. And so that raised questions about what the meaning was of the amyloid. In some instances, older individuals who have cerebral amyloid angiopathy have intracranial hemorrhages. And it's thought that maybe the amyloid deposits make the vessels fragile and they just break open and you get a hemorrhage. And it's a non-inflammatory mechanical process. But these, in that they would not respond to anti-inflammatory drugs. But the patients in our series all had, in addition, they had granulomatous inflammation, and they responded just like all of the other patients with vasculitis. They responded to corticosteroids. So it was an inflammatory process, and we're kind of starting to look into that a little bit. These are 2 nice photographs provided by Dylan Miller, our pathologist, showing granulomatous inflammation in this blood vessel here. And over on this side, you see multinucleated giant cells and destruction of the blood vessel wall. Again, a very pretty picture, especially if you're a histopathologist. And a lymphocytic type of vasculitis, only lymphocytes. I suppose you might be able to see some monocytes in there or something, but I couldn't. And the vessels are just really occluded by the dense inflammatory infiltration. And then finally, a necrotizing pattern with invasion by polymorphonuclear leukocytes, breakdown tissue destruction, necrosis of the vessel wall also. So what are the clinical findings in all of these 131 patients? This is the whole group here, and this is the biopsy confirmed and the angiograph confirmed. And you can see that it's a middle-aged disease. 48 years of age is the median, but there's quite a range of age. So again, you're dealing with individuals. It could happen at any age. But in general, it's not in old people like giant cell arteritis where the average age is about 70. Headache is the most common symptom. Altered cognition, meaning kind of confusion, of course, and general deterioration of mental function, and a hemiparesis or focal neurologic changes. Those are present in maybe 3/4 of the patients. So these are the common symptoms that you'd get suspicious about if you're thinking of central nervous system vasculitis. And then there are a variety of other symptoms as well, quite a few different symptoms. So it can present in a variety of ways, and the patients can have lots of different kinds of neurologic symptoms. But then on this one, we kind of compare biopsy and angiograms, and the only difference between the two groups was the presence of hemiparesis in the group that was angiographically identified. And this has been reported before, and as we submitted this paper, the reviewer jumped right on that and said, well, it's, you know, this is before, and maybe these patients are all vasoconstriction syndrome. Of course, we had to argue that that wasn't the case, and that we couldn't exclude that there might be a patient or two, and the editor eventually sided with us. That's just the nuts and bolts of publication. Then further symptoms in these 131 patients, visual symptoms are pretty common. There can be a variety of things: visual deficit, diplopia, blurred vision, even ischemic optic neuropathy. Intracranial hemorrhages, which can occur, are more, perhaps a little bit more common in the vasoconstriction syndrome, could, as you might expect, happen in vasculitis too, in all forms of vasculitis. And then a very disastrous symptom is a quadriparesis, paresis, or paraparesis. And constitutional symptoms are very uncommon. Most forms of vasculitis are associated with fatigue, fever, malaise, and so forth. But this is a different one. Even though there's inflammation going on, it's confined to the central nervous system, so that the patient can be simply confused. They suddenly develop these, and they're getting worse and worse, and there's just no evidence of the vasculitis. SED rate's normal too. Now this slide shows the initial symptoms. What are you going to see when the patient comes in? So again, it's the headache, altered cognition, and a stroke or persistent neurologic changes. Something's happened to that patient, and then we have about 3/4 of the patients in that group. And there's no difference between the two here. So that's the case, but it'd be just our luck to see a case and have it present in some unusual way. But that's all part of medicine. Regarding, as I mentioned, the laboratory tests are, general laboratory tests tend to be normal. So they aren't really very helpful. Anti-nuclear antibody tests, all those special tests are all negative too. The cerebrospinal fluid findings were reviewed in 104 patients, and the findings are abnormal in 92%, but they really, in general, the median values aren't very abnormal. If there is an intracranial hemorrhage or subarachnoid hemorrhage, of course, you're going to see lots of red blood cells. But in general, a CSF will help separate out an infection. The number of white cells is generally very low. If you have any kind of abnormalities I mentioned, you're going to see some minor abnormalities. So that's a clue that really something is going on in the CNS if you didn't already realize that. Well, what about the therapy in these patients? As we noted earlier, in the initial cases, they all died, so that it was considered to be a fatal disease. But as more cases were described, then the broader spectrum of the disease could be appreciated. And as I mentioned, the one term, benign angiopathy of the CNS, turned out not to be an inflammatory process, but probably vasoconstriction, but just wasn't recognized. So that it gets to be a little bit muddy at times. But in these patients, as best we could tell, they were all vasculitis or very close to it. You know, you can't really take a really completely positive stance if you're doing things by angiograms only. But at any rate, there were 43 patients who were treated with prednisone alone. After the diagnosis, they were started on therapy, and the median initial dose was 60 milligrams of prednisone, pretty standard for any kind of vasculitis. There were 25 patients who got intravenous pulses at the onset, and I just grouped those together for the sake of kind of coming to some kind of figure. 3/4 were treated for 19 months or less, and we had follow-up data on 42 of the 43 cases. And a favorable response was found in 34 of the 42, so 81%. So that was rather reassuring that these patients could be treated, at least improved to some extent. There were 46 patients who were treated with prednisone and cyclophosphamide, and these were patients seen by a variety of doctors. So the reasons they started on prednisone or prednisone plus cyclophosphamide weren't always so apparent. In general, the patients perhaps with more severe disease were given both drugs. And I grouped together those given oral cyclophosphamide and those given IV monthly pulses, such as might be given in Wegener granulomatosis. So the median oral dose was 150, again standard for vasculitis patients, and the median IV dose was 1,000 milligrams, again pretty standard for IV pulses. The median duration of treatment was less than a year here, and the response that we could follow 45 of the 46, and again, rather strikingly, the number improved was the same, 81%. So again, a favorable response, a little different from what was often reported in the literature. There were some recurrences in 1/4 of the patients. Some of them had 1 relapse, some 2, some even 3. And you know, if you want to be honest about it, you can't always be sure whether the disease had continued in an active state and they reduced the prednisone too fast or the drugs too fast, or whether this was really a clinical exacerbation. You can, if the patient is on a rather stable dose for a longer period of time or off, and then they get the symptoms maybe for a couple of months or more down the road, then you can be more confident that it's actually a recrudescence rather than just a little flare-up from inadequately suppressed disease. There were no associated clinical findings with those patients who had relapses. Of course, that might tend to prolong treatment, which it did. And it was of interest, I looked at the angiograms, and only 2 of those with just small vessel involvement had relapses. So there might be some clinical correlation there, but the numbers of patients was fairly small. 6 of the patients were from Olmsted County, and we've been involved over the years with epidemiologic studies, population studies, and we have a good handle of the number of persons in Olmsted County, and anybody with a significant illness comes to Mayo Clinic, so our ascertainment's pretty good. So we could do a calculation on incidence rates, and this turned out to be 2.3 cases per million person years. So again, it obviously confirms the fact that this is a rare, or if you will, an uncommon disease. Maybe in Edmonton you might see 2 or 3 cases a year, but you probably suspect it in more than that, so you need to be alert to it. The median follow-up for the entire group was 13 months with a range of none for those who died in 14 years. At last follow-up, 21 of the patients had died. And we graphed the survival rate according to Kaplan-Meier methods, and the patients in the population of 131 patients had an increased or decreased survival rate compared to the U.S. White population. And this was highly significant. And we've done that for giant cell arteritis, and the survival is normal for the entire group. So then we wanted to look at the kinds of symptoms that the patient had when they came to the clinic, to see if some symptoms were related to an increased death rate. And again, how about those diagnosed by biopsy versus angiograms? So we looked at age. Were the older people more likely to die? Turns out they weren't. And these were univariate Cox proportional hazards modeling. So a hazards ratio of 1 means that the two things that are being compared, there's no difference between them. So maybe the older people were a trifle more likely to have a fatal outcome, but the p-value is, you know, it was negative. Again, no difference between men and women. Headache, no difference there. Now, if you had a stroke, or if you had a cognitive disorder, some clear-cut neurologic deficit, then the hazard ratio was starting to go up, but the p-values really didn't reach statistical significance. Comparing those biopsy and angiograms, again, no difference between the two. What about the MRI findings? Now, if a patient had infarctions on MRI, then the hazard ratio had increased and the difference was significant. So an MRI showing an infarction, 1 or more infarctions in a CNS vasculitis, that's a bad sign, and the outlook is going to be worse. If there's gadolinium enhancing lesions, it's either in the meninges or within the parenchyma, the hazard ratio was very low. I was kind of surprised to see that, and it was significant. So these patients have a better than average outlook for CNS vasculitis. We'll talk about that in a minute. And if they had hemorrhage or infarction, there wasn't any difference. Now, if they had large vessel involvement versus small vessel involvement, then the hazard ratio was quite high, and the difference was significant. This is kind of something that fits in with common sense. If you have a very large vessel involved, you're going to have more brain damage, and so the outlook should be worse, and it is. If there was a treatment with prednisone only or Cytoxan, there was no difference. So we couldn't recommend that on the basis of this experience that you should treat with one or the other. What about a rapid onset? You'd think that it might be more severe and the patient's outlook would be worse. Didn't seem to be the case. Another way of looking at outcomes and progress is to use the Rankine score. If you're not a neurologist, you probably wouldn't be very familiar with this. This is an established way of scoring patients. It's 0 to 6 grades. 0 means no symptoms or findings neurologically. 6 is death. 1 is minimal neurologic symptoms. 5 would be fairly severe. So we put our patients in a table like this. These were the Rankine scores at diagnosis, and these are the numbers of patients at diagnosis that had those scores. There were 74 of the 131 patients, for example, who had a score of 0 to 2 and were fairly mild neurologically. 26 were moderate, 31 were more severe. And what happened to them? In order to make some consistency out of it, Teresa Christensen suggested that we divide the follow-up duration into less than a year, 1 to 5 years, and then 5 and 15 years, and see what happened to the patients. And just take, for example, of the 74 patients who had minimal neurologic changes to begin with and were followed less than a year, 34 stayed in that category, followed longer, 26 did, and still longer, 6 did. On the other hand, there were 8 of the patients in that group who died. So even though they came at the time, and at the time of diagnosis, the neurologic findings were fairly minimal, death could occur. If they were a little bit more severe at onset, they also seemed to stay in a minimal neurologic change during the follow-up. Again, several of them died. 5 of them died. And if they presented to some more severe degree at the diagnosis. Again, there was a death in eight of the group, but many of them improved at follow-up and were in the 0 to 3 Rankine score. Just to summarize that again, it's a little complicated table maybe the first time you see it. 66 of the 74 patients with low scores at diagnosis had a low score at follow-up. 38 of the 57 with an intermediate or high score, either these, stabilized or improved at follow-up. But 21 of the 131 patients had died during follow-up, and that's what accounted, obviously, for the increased mortality rate. But I think this is rather a good outcome for many patients, that the treatment seemed to be helpful and that the majority of them stabilized or improved with the therapy. So to summarize, the approach to diagnosis and therapy of PC and SV, of course you need to take a careful history and a physical exam to assess the patient's findings, make sure there's no secondary cause. Laboratory tests should be done, but they're going to be normal routine tests. And imaging with an MRI should be an early test. CT scans also show similar changes, but they're a little bit less sensitive in identifying CNS lesions. Arteriograms should be considered. An MRA would be perhaps the first test of choice there, less invasive. CNS biopsy should be considered. You know, even though we have been studying this, one just intuitively says it's a invasive procedure and proceed with caution. Now it turns out that most of the time a CNS biopsy is relatively benign. Once in a while with a needle biopsy there's a little hemorrhage around the site, and so that can happen. But as far as important complications in CNS biopsies, they're quite low. It's quite expensive though. You get a neurosurgeon in the operating room, it costs quite a bit of money nowadays. And the diagnosis is only tentative. You need to keep track of that without a tissue verification. But I think you can often proceed anyway. And if you don't feel confident, you should get a biopsy. And steroids could be considered alone for angiograms confirming the diagnosis. And when a biopsy is positive, then you can decide on sort of the severity of the disease. And you might give the patient pulses if there's progressive neurologic changes. There's a little bit of the art, I must confess, in the treatment of this yet, because there is just no strict guidelines. And as I mentioned here, Cytoxin and steroids for more severe patients whose symptoms suggest that you might have a severe or outcome. Now, as we looked at the cases, we were struck with there might be some subsets, and we've kind of separated off several groups of patients that we think could be a subset and might even be, in some instances, be a separate disease. We're kind of leaning toward the idea that primary CNS vasculitis is just not one disease, but it's several diseases that look quite similar clinically. And one of those is spinal enhancement. I'll show a little bit more about that. One is angiographic negative biopsy positive CNS, would indicate a small vessel vasculitis, too small to be seen on angiograms. Spinal cord involvement, probably just a variant. And then those with amyloid deposit. We need to have further investigation. And this rapidly progressive course is a group of patients whose outlook is very poor, who have large vessel involvement. It's probably just a group of patients who are not going to do very well. And then what about separating them by histopathology? I'm not sure about that yet, but it's something to keep in mind. Now, the patients who had prominent leptomeningeal enhancement, there were 8 of them, and at this point, our cohort was 101. Now we have 13 of these patients, but I just hadn't had time to analyze them like this, so I just used the older group. There was a little sex differentiation, not really significant. They presented with a cognitive dysfunction. This was generally pretty widespread throughout the leptomeningeal, so you might have a rather global involvement. CNS was different. It's not really world-shattering. Angiograms were not positive in any of the cases that were done, as you might expect, because the vessels turned out to be very small. And the CNS biopsy was positive in all of them. 6 of 8 had granulomatous histopathology, suggesting that that might fit, but it was not completely uniform. And amyloid deposits were present in some. Now this shows an MRI with the gadolinium enhancement in the meninges, in the sulci, pretty readily visible. And then after treatment, that enhancement is gone. So this is a kind of a distinctive appearance of an MRI, and there are some clinical correlates. At this time, it's still a little amorphous, but it certainly is a separate clinical appearance. What about the angiogram negative biopsy positive group? That's probably also small vessel vasculitis. Again, cognitive disorder. There's some overlap with these and the meningeal enhancement, but not completely. CNS was, protein was increased. There was enhancing lesions in 6. Now 2 of those were meningeal, but the other 4 were parenchymal. So there wasn't really a complete unanimity with the other group. And in some of these, they had multiple parenchymal punctate lesions were enhancing. It looked like these were associated with little blood vessels in the brain parenchyma. And again, with more experience, maybe that will turn out to be a diagnostic or pathognomonic type of lesion if you see it. It doesn't occur in all the patients. Histopathology was variable, so it doesn't hold together that it's completely uniform. And all responded to therapy. There were relapses in some, but none had an important neurologic deficit. So these patients had a good outlook, though. So the patients with leptomeningeal involvement in this group are quite similar: small vessel vasculitis, good outlook. And this shows a biopsy of one patient with very small vessels, clearly a vasculitic process invading the blood vessel wall. Spinal cord patients, there were 5 of them. Sometimes they had been excluded or cut off or separated off as a special syndrome. Interestingly, all had only thoracic involvement. But in some cases, it was before cerebral, some concurrently, and in 2, the involvement was after the diagnosis was made. So most of them have some type of cerebral involvement also. So I think that it's just a variation of the disease in location rather than a separate process. They have different kinds of histopathology and biopsy. It's 1 patient died, but 4 had relapses. They respond well to therapy. And in some instances, if they had severe spinal cord damage, there was some residual. And this shows an enhancing lesion in the lower thoracic cord, which is pretty typical of all the patients who had spinal cord involvement. And this patient had a biopsy here which showed vasculitis in the spinal cord arteries. So it's pretty clearly a vasculitis, but it's just a more broad spread involvement than the brain, and I think it's the same syndrome. So they should be included together. And then finally, the amyloid group. This is a biopsy diagnosis. The patients were somewhat older. As I mentioned, it's not uncommon for old people who die and have postmortem examinations to have amyloid angiopathy. It's just a sort of an incidental finding. So these patients were older than the average or median for the whole group, but not as old as the cases reported who have just amyloid angiopathy. Cognitive disorder, granulomatous histopathology, 100%, as though the amyloid is inciting a granulomatous inflammatory response. Some of them had gadolinium, and the enhancement and the outcome was similar. But the important thing is that it was an inflammatory process, and they did respond to therapy. So it turns out that in amyloid angiopathy, there's a broad spectrum. Some are just sort of benign incidental findings in the blood vessels. Some are non-responsive. And then there's this subgroup, somehow, that's a little bit younger and responds to treatment. And as I said, we're kind of looking into that a little bit. And you can see a parenchymal amyloid deposit around the blood vessel here, stain for amyloid positive, and then a trichrome stain, again, nicely illustrating the amyloid deposits. None of these patients had Alzheimer's disease. And then the rapidly progressive group, unfortunately, they've had large vessel disease. They may present with rather disastrous initial symptoms, and that's the way that's common. And they have bilateral cerebral infarctions on MRI due to the involvement of the large vessels in all 10 of the cases, 11 of the cases. And the outcome, 6 of those patients died within 1 month. So they don't, either they are just beyond responsiveness to the drugs or they're non-responsive. So this is if you see this type of course in a patient with large vessel involvement and rapid progression, these patients are facing a very dire outcome. So in summary, CNS vasculitis is an uncommon condition which does cause severe morbidity and death. The diagnostic angiograms and brain biopsy may be supplementary, so you just can't rest with either one necessarily. And I think our data show quite clearly in some cases angiograms could be negative and yet biopsies positive and vice versa. The more increased mortality appears to be related to focal neurologic changes, cognitive disorder, and then cerebral infarctions and large vessel involvement. So those are the findings you look for, and if you see any of those, then you try treating very vigorously. And a reduced mortality associated with small vessel disease with gadolinium-enhanced lesions in the meninges. I suspect that early diagnosis and treatment will reduce the permanent disability or death. You know, this is not a controlled trial or study, and this is just a conjecture on my part. But I think that CNS vasculitis, on the basis of our data, is more than one disease. And we're actually comparing our findings with a children's group from Toronto to see how they compare. But at least looks like the findings suggest that there's more than one syndrome here, the etiology of any of them isn't known at the present time. So I think I'll stop there. Thank you for your attention. And if there are any questions, I'll be happy to try to answer them. Thank you.
What's your thinking about what your colleagues have reported, the non-vasculitic autoimmune encephalitis or meningoencephalitis with the perivenial or lymphocytic infiltrate? And again, I was thinking that in my mind, sometimes that comes up as because the patients can present confusion and headache, and obviously in the end they don't have vasculitis.
Yes, well, that is, there's a lot of unknowns about these conditions. And that's one of them where we don't really understand it too well. And from a practical standpoint, I mean, you do your best, you do your studies, and then if you see the biopsy findings, and then that's probably all you can do, maybe cultures, and then you try empiric treatment. I'm sorry I can't give you much of a better answer. Those patients are really quite uncommon.
And the treatment's the same.
The treatment's the same. And we saw, I don't know if I was in on that article or not, it's by the Arizona group. Yeah, and Rick Caselli and some of the other guys, the neurologists down there, we had a patient in the psychiatry ward who had a mental decline with symptoms of psychosis. And I've forgotten exactly why now. We gave the patient a large dose of steroids and she came right around. And so there was an interest, and the neurologist took it forward from there. And then we had a small group patients that they reported.
Thank you.
Mm-hmm. Was that another question?
Oh, the only other question was that you collect a bunch of biopsies, and in general, as you said, there's minimal morbidity. But have you ever gotten a neurosurgery resident to kind of look at the morbidity of your biopsy series?
No, I think the pathologists have.
Yeah.
And it's relatively minimal. But I have seen where there's a little hemorrhage around the biopsy site, and rather not have it done myself. I don't mean to be funny.
Thank you for your elegant talk, and thanks to the Rheumatology Division for inviting a neuroscience speaker.
You're entirely welcome.
And so my question is, you've distilled this down to those patients who were ultimately diagnosed with this condition. But do you have a sense of how many patients were investigated? And what proportion, how many do you have to investigate to make the diagnosis? So we're obviously thinking about this condition in many circumstances, and we get a lot of doubt cast upon our thinking about zebras when horses are galloping by.
Well, that's true. We don't have a good number about that. And if you're seeing a patient in the ward and someone said that could this be seen as vasculitis, you look at it and kind of decide whether you should go forward with other tests. But that isn't registered anywhere, really. Would be not a diagnostic item. So there'd be really no way to assess that. I'm sure it's a very small proportion, though. If we have, we have 50 cases of giant cell arteritis a year. And there's 131 of these over 25 years. So many are called, but few are chosen, may be apt words here. But because it's important, you need to pursue it. And try to balance off the clinical risks of doing the procedures versus what the findings are. And as time goes on with patients and they seem to be stable, you don't need to be as aggressive. If they're progressive, the course is progressive, you need to go ahead. The risk becomes greater for sitting and doing nothing. And you can look at the data of the angiogram negative, biopsy positive ones. Maybe there'll be some meningeal enhancement, maybe some other findings that will weigh your decision to go ahead with the biopsy. But the consideration, I'm sure, comes up many more times than the diagnosis is actually made.
We perhaps have time for one more question.
There's no disagreements?
Well, thank you again very much, Dr. Hunder, and it's a wonderful opportunity. Thank you.